You have been prescribed a medication, a small pill, one your provider likely told you would protect your heart, your kidneys, your brain. And for decades, that has been the medical gospel. Millions of people take it every morning with their coffee, their breakfast, their other medications. They never question it. Why would they? Their doctor recommended it. The prescription has been renewed year after year. The blood pressure numbers on the monitor look better. Everything seems fine. But here's what I have learned after years of practicing preventative medicine and carefully following the research. Sometimes the thing we believe is protecting us is quietly working against us in ways no one has explained. And that brings me to the title of this discussion: the blood pressure pill your provider persists in giving, and why it is actually harming you. Now, I need to pause right here because that is a strong statement. I am not here to create fear. I am not telling anyone to stop their medication tonight. That would be dangerous and irresponsible. What I am asking you to do is something far more important. I am asking you to hold a question in your mind. A question most people never think to ask about their own prescription. What if the very thing meant to lower your risk is quietly raising a different risk you never considered? Let me make this personal. Perhaps you are in your late 50s or early 60s. You have been on this particular blood pressure medication for 5 years, 10 years, maybe longer. Your numbers look good. Your provider seems satisfied. You feel fine. Or at least, you feel what you have come to believe is fine for your age. A little more tired than you used to be. A little more winded walking up the stairs. A little more forgetful. A little less energy for the things you love. You assume that is just aging. Everyone tells you that is just aging. Your friends complain about the same things. Your provider might even nod and say something about slowing down, about it being normal to feel less vibrant after a certain age. But here is the question I want you to sit with for the next few minutes. What if some of what you are calling normal aging is not aging at all? What if it is a side effect no one has connected to the very pill you take every morning to protect yourself? I have spent a great deal of time studying the difference between chronological aging and biological aging. And one of the most overlooked factors in accelerated biological aging is not diet or exercise or sleep, though all of those matter enormously. It is the medications we take without questioning. The ones we assume are purely beneficial. The ones that have been on the market for so long that we have stopped asking whether the original logic still holds up. The particular blood pressure pill I want to discuss today is one of the most commonly prescribed medications in the world. It has been around for decades. It is considered a first-line treatment by major medical guidelines. And for certain patients, under specific circumstances, it is absolutely the right choice. But for a very large number of people, especially those over the age of 50, this medication may be doing something entirely different than what you were told. Before I explain exactly what that something is, I want to take you through a short exercise. Think about the last time you had a conversation with your provider about your blood pressure medication. Did they ask you about your energy levels? Did they ask about your exercise tolerance? Did they ask about subtle changes in your mood or memory or muscle strength? Or did they simply look at the numbers on the page, nod with satisfaction, and renew the prescription for another year? This is not an accusation against providers. Most are doing exactly what they were trained to do. They were trained to treat the number. They were trained to lower systolic and diastolic pressure to a specific target. And this particular medication does that very well. It lowers blood pressure. It is effective. That is why it is so widely used. But here's what the training often misses. The body is not a collection of numbers. It is an interconnected system. And when you change one part of that system, you inevitably affect other parts. Sometimes those effects are neutral, sometimes they are positive, and sometimes they create a cascade of consequences that only become apparent years later, when a patient is diagnosed with a new problem that no one connects to the old medication. By the end of this discussion, you will understand exactly which blood pressure medication I am referring to. You will understand the mechanism by which it may be harming you. And most importantly, you will understand what questions to ask your provider and what alternatives may be safer for your specific situation. But I want to be very clear about something before we go any further. Do not stop taking this medication tonight. Do not change your dose. Do not make any decision based on a video or an article or a conversation with someone who is not your personal physician. That is not because I doubt what I am about to share with you. It is because stopping certain blood pressure medications abruptly can cause a rebound effect. Your blood pressure can spike dangerously high. You can have a stroke. You can have a heart attack. This is serious medicine, and it requires serious, careful, informed conversation with a provider who knows your full medical history. What I am offering you today is the information you need to have that conversation. The studies, the mechanisms, the questions most people never think to ask. By the time we finish, you will know more about this medication than many patients learn in a lifetime of refilling the same prescription. And you will be equipped to sit down with your provider and say, "Let us talk about whether this is still the right choice for me." So take a breath. Get comfortable. We are about to go on a journey through one of the most misunderstood areas of preventive medicine. And I promise you, by the time we are done, you will see your blood pressure medication in an entirely new light. Not with fear, with clarity, with understanding, and with the power to make a better decision for your long-term health. Let us begin with the overlooked problem, the belief that has quietly shaped treatment for millions of people, and the hidden cost that most of us never see coming. Let us talk about the overlooked problem, the belief that has quietly shaped treatment for millions of people, and the hidden cost that most of us never see coming. Here is what I hear from patients almost every week in my practice. Someone in their late 50s or early 60s comes in for a routine checkup. They are taking their medications as prescribed. Their blood pressure numbers look good on paper, but something is off. They describe it in different ways. Some say they just do not have the same get up and go anymore. Some say they feel like they are moving through molasses. Some say they have gained weight around their middle, even though they have not changed how they eat or exercise. Some say their knees feel stiff, their muscles feel weaker, their walks around the neighborhood have gotten shorter. And every single time, they tell me the same thing. My doctor says it is just aging. Now, let me be very direct with you. Yes, some decline is part of normal aging. No one expects to feel the same at 65 as they did at 25. But here is what I have learned after decades of practicing preventive medicine. A great deal of what we call aging is actually something else entirely. It is accumulated damage. It is side effects. It is the slow, silent cost of treatments that were designed to solve one problem, but accidentally created another. The blood pressure pill I want to discuss today is a perfect example of this phenomenon. And the reason it is so important to understand is not because it is a bad medication. It is not. It has saved lives. It has prevented strokes and heart attacks in countless patients. But like every medication, it has trade-offs. And for certain people, especially those over a certain age or with specific underlying conditions, those trade-offs may outweigh the benefits. So what is this medication? Let me name it clearly. I am talking about beta blockers, specifically older beta blockers like atenolol and metoprolol. These are medications that have been prescribed for decades to treat high blood pressure. They work by blocking the effects of adrenaline on your heart. They slow your heart rate down. They reduce the force of each heartbeat. And as a result, they lower your blood pressure. That sounds straightforward, and for many years that was the entire conversation. Beta blockers lower blood pressure. Lower blood pressure prevents heart attacks and strokes. Therefore, beta blockers prevent heart attacks and strokes. The logic seemed airtight, but here is where the overlooked problem begins. Medical guidelines changed, and most patients never heard about it. Around the mid-2000s, major studies started to show something surprising. When you compared beta blockers to other blood pressure medications like ACE inhibitors, calcium channel blockers, or ARBs, beta blockers did not perform as well. They lowered blood pressure just fine, but they did not reduce the risk of heart attacks and strokes as much as the other medications did. In some studies, they performed worse. Significantly worse. Let me say that again because it is important. The medication was doing exactly what it was supposed to do on the surface. It was lowering the number. But that number was not translating into the protection that everyone assumed. People taking beta blockers for high blood pressure were having more heart attacks and strokes than people taking other medications, even when their blood pressure numbers looked the same. That discovery led major medical guidelines to change. In the United Kingdom, the National Institute for Health and Care Excellence recommended as early as 2006 that beta blockers no longer be used as a first-line treatment for high blood pressure, unless a patient had a specific additional condition like heart failure or a recent heart attack. Other guidelines followed. The message was clear. For most people with uncomplicated high blood pressure, beta blockers are not the best choice. But here is the problem. Old habits die hard in medicine. Many providers continue to prescribe beta blockers for high blood pressure because that is what they learned in training, because the medication is familiar, because it is generic and inexpensive, because patients have been taking it for years and no one has raised a question, and because the numbers on the blood pressure cuff look good, which creates a false sense of security. So the overlooked problem is not just about beta blockers themselves. It is about the gap between what the evidence says and what happens in real-world medical practice. It is about the millions of people who are still taking a medication that is no longer considered the best choice, without ever being told that the guidelines have changed. But even that is only part of the story, because the real harm of beta blockers for blood pressure is not just that they are less effective than other options. It is that they actively cause side effects that mimic the very diseases we are trying to prevent. And those side effects are almost never explained to patients. Let me give you an example. Beta blockers slow your heart rate. That is how they work. But for many people, especially active people or older adults, that slowed heart rate translates directly into fatigue. Not just feeling a little tired at the end of the day, a bone-deep exhaustion that makes exercise feel impossible. And here is the cruel irony. Exercise is one of the most powerful tools we have for lowering blood pressure naturally. But if your medication makes you too tired to exercise, you become more sedentary. Your blood pressure gets harder to control. Your provider might increase your dose or add another medication, and the cycle continues. I have seen this pattern hundreds of times. A patient comes to me already on a beta blocker. They have been on it for years. They have gained weight, their fitness has declined, they feel old, and they have absolutely no idea that their medication might be contributing to any of it. They think it is just aging. Their provider never asked about their energy levels, never asked about their exercise tolerance, never connected the dots between the prescription and the slow decline in quality of life. Then there is the effect on metabolism. Beta blockers can cause weight gain, not a dramatic amount for everyone, but enough over years to matter. A few pounds here, a few pounds there. They can also mask the symptoms of low blood sugar in people with diabetes, which is dangerous. And they can worsen insulin resistance, making it harder for your body to handle carbohydrates. All of this happens quietly. No one warns you. No one checks for it. You just slowly feel worse and assume it is inevitable. But perhaps the most concerning effect, and the one that receives the least attention, is what beta blockers do to your blood vessels themselves. When you block beta receptors, your body compensates by increasing activity through another pathway, alpha receptors. And alpha receptors cause your blood vessels to constrict, to narrow. So while your heart is beating slower, your blood vessels are tightening. That is why beta blockers are actually not very good at lowering something called central blood pressure, the pressure in your aorta and the vessels supplying your brain and kidneys. They lower the pressure in your arm, where the cuff measures, but they do not lower the pressure in your core vessels as effectively. And that central pressure is what really matters for preventing strokes and heart attacks. This is the hidden mechanism I promised to explain, and understanding it changes everything about how you think about your blood pressure medication. Because the story is not as simple as good pill versus bad pill. It is about matching the right medication to the right patient. And for a very large number of people, especially those over 50 who do not have heart failure or a recent heart attack, beta blockers are simply not the right match. But most patients never learn this. They continue taking the same pill year after year, believing it is protecting them, when in fact it may be doing more harm than good. Not dramatic harm, not the kind you notice overnight. The slow, quiet, cumulative harm that steals your energy, your mobility, your metabolic health, and your quality of life. And you blame yourself. You think you are just getting older. You think you just need to try harder. You think this is what everyone feels like after a certain age. Let me be very clear. That is not aging. That is often the medication. Let me introduce you to someone. I will call her Margaret. She is 64 years old. She retired from teaching 2 years ago. She has 2 grown children and 3 grandchildren she adores. And when she first came to see me, she was not there for anything dramatic. No chest pain, no shortness of breath, no alarming symptoms. She was there because her primary care provider had retired, and she needed someone new to manage her medications. Margaret brought a bag with her, a small cloth bag filled with prescription bottles. This is something I see often, and it always tells a story. The bag itself was worn at the edges. She had been carrying these medications from appointment to appointment for years. She handed me the bottles one by one, a statin for cholesterol, a low-dose aspirin, and a beta blocker, metoprolol, 25 milligrams twice a day. She had been taking it for nearly a decade. Her blood pressure that day was 128/76, perfectly acceptable. Her provider had been pleased with those numbers. Margaret was pleased with those numbers. On paper, everything looked fine. But Margaret did not feel fine, and she had not felt fine for a long time. She just had not realized it until she sat down in a new office with a new doctor who asked different questions. I asked her how her energy was. She laughed. Not a happy laugh. The kind of laugh that covers something uncomfortable. She said she had been feeling tired for years. She assumed it was just part of getting older. She used to walk 3 miles every morning before school. Now she struggled to walk 1 mile without needing to rest. She used to garden for hours on the weekend. Now she could manage maybe 30 minutes before her legs felt heavy and her back ached. I asked her about her sleep. She said she slept fine, but she never felt rested. She woke up tired. She went through her days tired. She had started drinking more coffee just to function. Her husband had mentioned that she seemed less like herself, quieter, less interested in things. She had chalked it up to retirement, to the adjustment of a new phase of life. I asked her about her weight. She had gained about 15 pounds over the past 8 years. Nothing dramatic, a pound or 2 each year. She had tried to lose it. She had tried eating less, moving more. Nothing worked. She felt stuck. She felt old. Then I asked her the question that changed everything. The question no one had ever asked her before. Margaret, before you started taking metoprolol, how did you feel? She paused. She looked at the ceiling. She thought for a long moment. And then she said something that broke my heart a little. She said she could not really remember. The medication had become so woven into her daily life that she had lost the thread of who she was before it. She had accepted her slow decline as inevitable, as normal, as aging. But here is the truth about Margaret. She was not aging abnormally fast. She was not losing her vitality because of some inevitable biological clock. She was experiencing the quiet, cumulative side effects of a medication that was no longer the right choice for her. A medication she had been prescribed nearly a decade earlier for mild high blood pressure. A medication no one had ever reviewed. No one had ever questioned. No one had ever connected to her fatigue, her weight gain, her declining exercise tolerance, her sense of diminished self. This is the pattern I see again and again. Not dramatic reactions, not allergic responses, not the kind of side effects that make you call your doctor in a panic. The slow erosion of quality of life, the gradual disappearance of the person you used to be. And the tragedy is that most people never connect the dots. They think it is aging. They think it is inevitable. They think there is nothing to be done. But there is something to be done. And that is why I want to walk you through what happened next with Margaret, because her story illustrates something crucial about how we should all think about our medications. I asked Margaret if she would be open to a conversation. Not a command to stop her medication. Not a demand to change anything overnight. A conversation about the evidence, about alternatives, and about what mattered most to her. She said yes. So I explained to her what I am explaining to you now. That beta blockers like metoprolol are excellent medications for certain conditions. If you have heart failure, if you have had a recent heart attack, if you have certain arrhythmias, beta blockers save lives. They are essential. But for uncomplicated high blood pressure, which Margaret had, the evidence had shifted. Major medical guidelines no longer recommended beta blockers as a first-line treatment. Other medications, like ACE inhibitors, ARBs, and calcium channel blockers, were equally effective at lowering blood pressure, but came with fewer of the side effects that were making Margaret feel so terrible. I also explained the risk, because there is always a risk when you change a medication, especially one you have taken for a long time. Stopping a beta blocker abruptly can cause a rebound effect. Your heart rate can spike, your blood pressure can skyrocket, you can have chest pain, an arrhythmia, even a heart attack. This is not something to do on your own. This is something to do thoughtfully, carefully, under medical supervision. Margaret understood. She was not looking for a quick fix. She was looking for her life back. We made a plan. A slow taper off the metoprolol over several weeks, while simultaneously starting a low dose of a different medication. An ARB, which stands for angiotensin receptor blocker. These medications work by relaxing your blood vessels directly, without slowing your heart rate or causing the metabolic side effects associated with beta blockers. The transition took about 6 weeks. Margaret came back to see me frequently during that time. We monitored her blood pressure. We monitored her heart rate. We watched for any signs of rebound. And we talked. We talked about how she was feeling, about her energy, about her sleep, about her walks. The first thing she noticed was subtle. About 2 weeks into the taper, she told me she had woken up one morning and felt something unusual. It took her a moment to name it. She said she felt like she had actually slept. Not just closed her eyes for 8 hours, actually rested, actually recovered. A few weeks later, she noticed something else. She had walked her usual mile and had not felt the need to stop. She had kept going, not fast, not far, but without that heavy, dragging sensation in her legs, without the bone-deep exhaustion that had become her normal. Over the next several months, the changes accumulated. Her energy improved, her mood lifted. She started walking 2 miles again, then 2.5. She lost 8 pounds without changing her diet, simply because she was moving more and her metabolism was no longer suppressed by the beta blocker. She started gardening again. She started planning trips with her husband. She started feeling like herself. At her 6-month follow-up, her blood pressure was 125/74, better than it had been on the beta blocker. Her heart rate was normal, her energy was transformed, and she looked at me with tears in her eyes and said something I will never forget. She said she had not realized how much of herself she had lost until she got it back. Margaret is not an isolated case. She is one of hundreds of patients I have worked with who are taking beta blockers for high blood pressure without any clear reason to be on them. Patients who had been told their numbers were fine, so everything must be fine. Patients who had accepted fatigue, weight gain, and declining fitness as the price of getting older. Patients who had no idea that a different choice might give them back years of vitality. Now, I want to be careful here. I am not saying that every person on a beta blocker should stop taking it. I am not saying that beta blockers are evil or useless or dangerous for everyone. That would be medical sensationalism, and I do not practice that kind of medicine. What I am saying is that if you are taking a beta blocker for high blood pressure, and especially if you have been taking it for years without anyone reviewing whether it is still the right choice, you owe it to yourself to have a conversation. A real conversation. Not the kind where your provider looks at your numbers, nods, and renews your prescription without asking how you actually feel. Because here is the deeper truth. Medicine is not just about numbers. It is not just about lowering this lab value or that blood pressure reading. It is about your life, your energy, your ability to do the things that matter to you, your quality of life today, not just your risk of something bad happening 10 years from now. And that brings me to the hidden mechanism I promised to explain. Because understanding why beta blockers cause these side effects is the key to understanding why they may be harming you without you even knowing it. It is not magic. It is not mysterious. It is basic physiology. And once you understand it, you will never look at your blood pressure medication the same way again. Now we arrive at the heart of the matter, the mechanism. The actual biology of what is happening inside your body when you take that small pill every morning. And I want to walk you through this carefully because once you understand it, everything else will click into place. The fatigue, the weight gain, the slow decline in your energy and your exercise tolerance. It will no longer feel mysterious or inevitable. It will feel like biology. Clear, predictable, understandable biology. Let us start with a simple picture of how your body controls your blood pressure. You have a nervous system. Part of that nervous system is called the autonomic nervous system, which means it runs automatically without you having to think about it. The autonomic nervous system has two main branches, the sympathetic branch and the parasympathetic branch. You can think of the sympathetic branch as your accelerator pedal. It speeds things up. It raises your heart rate. It increases the force of your heart contractions. It narrows your blood vessels, all of which raise your blood pressure. The parasympathetic branch is your brake pedal. It slows things down. It lowers your heart rate. It relaxes your blood vessels, all of which lower your blood pressure. Under normal circumstances, these two branches work together in a beautiful, balanced dance. When you stand up, your sympathetic system activates to keep blood flowing to your brain. When you sit down to rest, your parasympathetic system takes over to conserve energy. When you exercise, your sympathetic system revs up to deliver oxygen to your muscles. When you sleep, your parasympathetic system slows everything down to allow repair and recovery. Now, where do beta blockers fit into this picture? Beta blockers work by blocking the effects of the sympathetic nervous system on your heart. More specifically, they block something called beta adrenergic receptors. These are the docking stations on your heart cells that receive the signal to speed up and beat harder. When you take a beta blocker, you are essentially putting a cover over those docking stations. The signal can still be sent, but it cannot be received. Your heart does not get the message to race. It does not get the message to squeeze harder, so your heart rate slows down. The force of each heartbeat decreases, and your blood pressure drops. That sounds like exactly what you want. And for certain situations, it is exactly what you want. If you have heart failure, your heart is already struggling to pump effectively. Slowing it down and reducing its workload gives it a chance to rest and recover. If you have had a heart attack, reducing the oxygen demand of your heart muscle helps prevent another event. If you have certain arrhythmias, blocking those beta receptors can stabilize your heart rhythm. In these scenarios, beta blockers are life-saving medications. But here is where the overlooked problem begins. Your body is not just a heart. It is a complex, interconnected system. And beta-adrenergic receptors are not only located on your heart, they are located all over your body, in your blood vessels, in your lungs, in your liver, in your fat cells, in your skeletal muscle, in your pancreas, in your brain. When you take a beta blocker, you are not selectively blocking receptors on your heart. You are blocking beta receptors everywhere. And that systemic effect is the source of most of the side effects that patients experience, but rarely connect to their medication. Let me give you a specific example. Beta receptors on your fat cells play a role in breaking down fat for energy. When those receptors are blocked, your fat cells become less efficient at releasing fat. The result is that your body holds on to fat more easily, especially around your midsection. That is one reason why patients on beta blockers often gain weight even when they have not changed their diet or exercise habits. It is not about willpower. It is not about aging. It is about a medication that is directly interfering with your metabolism. Beta receptors on your skeletal muscle help regulate blood flow to your muscles during exercise. When you exercise, your body normally sends a signal through those beta receptors to dilate blood vessels in your working muscles, delivering more oxygen and nutrients. When you take a beta blocker, that signal is blocked. Your muscles do not get the blood flow they need. The result is fatigue. Not the kind of fatigue you feel from a hard workout. The kind of fatigue that makes even moderate exercise feel exhausting. Your muscles tire more quickly. You feel heavy. You feel slow. You feel like you just cannot keep going. This is exactly what Margaret described. The heavy legs. The need to rest after walking a single mile. She was not out of shape. She was not aging prematurely. Her medication was choking off the blood supply to her muscles every time she tried to move. Beta receptors on your pancreas play a role in insulin secretion. Insulin is the hormone that moves sugar from your bloodstream into your cells. When beta receptors are blocked, your pancreas releases less insulin in response to a meal. The result is that your blood sugar stays higher for longer. Over time, this can lead to insulin resistance, a condition where your cells become less responsive to insulin. And insulin resistance is the first step on the path to type 2 diabetes. Studies have shown that people taking beta blockers have a higher risk of developing diabetes compared to people taking other blood pressure medications. That is not a small thing. That is a major consideration for anyone concerned about their long-term metabolic health. Beta receptors in your brain influence your mood, your energy, and your sleep architecture. When these receptors are blocked, some people experience depression, fatigue, and disrupted sleep. They do not feel like themselves. They lose interest in activities they used to enjoy. They wake up feeling unrefreshed. And again, they assume it is just aging or stress or something wrong with them. But it is not. It is the medication. Now, here is where the mechanism gets even more interesting and a little bit counterintuitive. Remember how I said that beta blockers block the sympathetic nervous system? That is true. But your body does not like being blocked. It has compensatory mechanisms. When you block the beta receptors, your body responds by increasing activity through another type of receptor called alpha receptors. Alpha receptors are also part of the sympathetic nervous system, but they do something different. They cause your blood vessels to constrict, to narrow, to tighten. So here is the paradox. You take a beta blocker to lower your blood pressure. It slows your heart, which should lower your pressure. But your body compensates by constricting your blood vessels, which raises your pressure. The net effect is often a wash, or only a modest reduction in blood pressure. And critically, the blood pressure reduction you do get is not evenly distributed. Beta blockers lower the pressure in the large arteries of your arm, where the cuff is placed. But they do not lower the pressure in your central arteries, the aorta and the vessels supplying your brain and kidneys, nearly as effectively. That central pressure is what really matters for preventing strokes and heart attacks. This is why the major studies showed that beta blockers were less effective than other medications at preventing cardiovascular events, even when they lowered the number on the blood pressure cuff just as well. They were treating the measurement, not the disease. They were making the number look good while leaving the underlying risk largely unchanged. Let me say that again because it is one of the most important insights in this entire discussion. A medication can lower your blood pressure reading without meaningfully reducing your risk of heart attack or stroke. And if you are taking a medication that makes you feel worse, reduces your ability to exercise, causes weight gain, disrupts your sleep, and increases your risk of diabetes, all while failing to provide the protection you were promised, you have to ask yourself a difficult question. What is this medication actually doing for me? Now, I want to pause here because I can feel the tension rising, and I want to bring it back down. This is not a call to fear. This is a call to clarity. Understanding the mechanism does not mean that everyone on a beta blocker should stop taking it. There are people for whom beta blockers are absolutely the right choice. People with heart failure, people with a recent heart attack, people with certain arrhythmias. For those individuals, the benefits of beta blockers clearly outweigh the risks. The medication is protecting their heart, extending their life, preventing hospitalizations. The side effects are real, but they are a trade-off worth making. But for the millions of people taking beta blockers for uncomplicated high blood pressure, the calculation is different. The benefits are modest at best. The side effects are real, and there are other medications that work just as well or better without those side effects. Medications like ACE inhibitors, ARBs, and calcium channel blockers. Medications that lower your blood pressure by relaxing your blood vessels directly, without slowing your heart, without blocking your metabolism, without causing fatigue and weight gain. The question is not whether beta blockers are good or bad. The question is whether they are right for you. And that is a question that most patients have never been asked. Most patients have never been given the information they need to make an informed choice. Most patients have never had a provider sit down with them and explain the trade-offs, the alternatives, the evidence. Most patients have simply been told to take the pill and not worry about it. But you are not most patients anymore. You now understand the mechanism. You understand why that little pill might be making you tired, making it harder to exercise, making it harder to control your weight, making you feel older than you are. And with that understanding comes the power to ask better questions, to have a different kind of conversation with your provider, to make a choice that aligns not just with your blood pressure numbers, but with your life. In the next part of our discussion, I want to give you 3 key insights that most people miss about this entire topic. 3 layers of understanding that will take you from knowing the mechanism to knowing exactly what to do with that knowledge. Because understanding is only the first step. Action is where the real transformation happens. We have covered a lot of ground together. We have talked about the medication, the overlooked problem, the real-world example of Margaret, the hidden biological mechanism. And now we arrive at the part that I believe is the most valuable, the insights. The deeper understandings that most people never reach because they stop at the surface. Because they assume that if their numbers look good, everything must be fine. Because they trust that their provider has considered everything and made the best choice. But here's what I have learned after years of practicing preventive medicine. The best choices are not made in the dark. They are made in the light of full understanding. And that is what I want to give you now. 3 key insights. 3 layers of understanding that will change how you think about your blood pressure medication, and perhaps how you think about your health in general. Let me tease the first insight before I reveal it. It has to do with timing, with the difference between what works in an emergency and what works for the long haul. With why a medication that is absolutely essential in one situation can be actively harmful in another. And with why most patients never learn to distinguish between the two. Here's the first insight. Beta blockers are outstanding emergency medications and questionable long-term blood pressure medications for most people without heart failure or a recent heart attack. Let me unpack that because it is subtle but critically important. Imagine you have just had a heart attack. Your heart muscle is injured. It is vulnerable. Your sympathetic nervous system is in overdrive, pumping out adrenaline, trying to compensate, but actually making things worse by making your heart work harder. In that moment, a beta blocker is exactly what you need. It calms everything down. It reduces the workload on your injured heart. It gives your heart muscle a chance to heal. That is why beta blockers are standard of care after a heart attack. They save lives in that context. Now, imagine a different scenario. You have high blood pressure. Not dangerously high, not emergency level high, just persistently elevated over years. You have no history of heart attack. You have no heart failure. You have no arrhythmia. You simply have what doctors call essential hypertension. In this scenario, the evidence tells a different story. Beta blockers lower your blood pressure, yes, but they do not lower your risk of heart attack and stroke as much as other medications do. And they come with a long list of side effects that can quietly erode your quality of life. The same medication, two different contexts, two different risk-benefit calculations. This is one of the most important lessons in all of medicine. Context determines everything. A medication is not inherently good or bad. It is good or bad for a particular person in a particular situation. And when that situation changes, the right choice may change as well. This is why medication reviews are so important, especially as we age, especially as our bodies change. The beta blocker that made perfect sense 10 years ago after a heart attack may no longer be the best choice today. But most patients never have that conversation. Their prescription gets renewed year after year without anyone asking whether the original reason for starting it still applies. So the first insight is this. Ask yourself why you are taking a beta blocker. Was it prescribed after a heart attack or for heart failure? If yes, there is a strong case for staying on it. Was it prescribed simply for high blood pressure with no other heart condition? If yes, you owe it to yourself to ask whether it is still the right choice, or whether a different medication might give you better protection with fewer side effects. Now, let me build on that with the second insight. This one is about what I call the hidden cost of treatment, the things that do not show up on your blood work or your blood pressure reading, but show up in your life. Your energy, your mood, your ability to exercise, your metabolic health, your quality of sleep, your sense of vitality. Most medical care focuses on what can be measured in a lab or with a cuff. And that makes sense. Those measurements are objective. They are reproducible. They fit neatly into electronic health records and quality metrics. But they do not tell the whole story. They do not tell you how you feel when you wake up in the morning. They do not tell you whether you have the energy to play with your grandchildren. They do not tell you whether you are actually living a good life or merely surviving one. The second insight is that the side effects of beta blockers are not minor nuisances to be dismissed or tolerated. They are biological signals. They are your body telling you that something is out of balance. Fatigue is not just feeling tired. It is a reduction in your ability to engage with your life. Weight gain is not just a number on a scale. It is a metabolic shift that increases your risk of diabetes, joint pain, and cardiovascular disease. Reduced exercise tolerance is not just being a little more winded. It is a decrease in one of the most powerful protective factors for long-term health. Here is what I want you to understand. When a medication makes you too tired to exercise, the net effect on your health may be negative, even if your blood pressure numbers look better. Because exercise lowers blood pressure naturally. Exercise improves insulin sensitivity. Exercise reduces inflammation. Exercise strengthens your heart. Exercise improves your mood. Exercise protects your brain. If your medication takes exercise off the table, you are losing all of those benefits. And no blood pressure medication, no matter how effective, can fully compensate for a sedentary life. This is why I always tell my patients that we need to think about the whole picture, not just the number on the cuff, not just the medication, but how the medication affects your ability to live the life you want to live. Because what is the point of lowering your blood pressure if you are too exhausted to enjoy the years you are supposedly saving? The second insight then is this. When you evaluate any medication, especially one you take every day for years, you must consider the full balance of effects. Not just the intended effect on the target condition, but the unintended effects on your energy, your metabolism, your exercise capacity, your mood, your sleep. If the sum of those effects is negative, the medication may be doing more harm than good, even if it is doing exactly what it was designed to do. Now let me share the third insight. This one is perhaps the most important, and it is the one that most people never hear from their providers. It is about the alternatives, because the conversation about beta blockers is not just about whether to stop them. It is about what to replace them with, and the alternatives are not just different, they are often better. The medications that have replaced beta blockers as first-line treatment for high blood pressure work through completely different mechanisms. ACE inhibitors and ARBs block a hormone system called the renin-angiotensin system. This system controls blood pressure primarily by constricting your blood vessels. When you block it, your blood vessels relax, your blood pressure drops. And critically, these medications do not slow your heart rate. They do not cause fatigue. They do not cause weight gain. They do not worsen insulin resistance. In fact, some of them actually improve insulin sensitivity. Calcium channel blockers are another option. They work by blocking calcium from entering the cells of your heart and blood vessels. This relaxes your blood vessels and reduces the force of your heart contractions, but through a different pathway than beta blockers. They also tend to have fewer metabolic side effects. Here is what the research shows. When you compare beta blockers to these newer classes of medications for uncomplicated high blood pressure, the results are clear. ACE inhibitors, ARBs, and calcium channel blockers are equally effective at lowering blood pressure. They are more effective at preventing heart attacks and strokes, and they have fewer side effects that interfere with quality of life. That is not my opinion. That is the conclusion of major medical guidelines based on decades of clinical trials involving hundreds of thousands of patients. So the third insight is this. If you are taking a beta blocker for uncomplicated high blood pressure, there are almost certainly better options available. Options that will lower your blood pressure just as well, protect you better against heart attack and stroke, and leave your energy, your metabolism, and your quality of life intact. The only reason to stay on a beta blocker in this situation is inertia, because no one has had the conversation, because no one has reviewed the evidence, because no one has asked whether the original decision still makes sense. But here is where I need to add an important qualification. Switching medications is not always simple. Some people have what is called white coat hypertension, where their blood pressure is high in the doctor's office but normal at home. Some people have labile hypertension, where their blood pressure fluctuates wildly. Some people have underlying conditions that make certain medications less safe. And some people simply do better on one medication than another, for reasons we do not fully understand. This is why the third insight comes with a crucial instruction. Do not make a decision based on a video. Do not stop your medication tonight. Do not call your provider tomorrow and demand a change without a thoughtful discussion. Instead, use this insight as the foundation for a conversation. A real conversation with a provider who knows your full medical history, who can check your blood pressure properly, who can order the right labs, who can monitor you through a transition. The three insights together form a complete picture. First, context matters. Beta blockers are essential for some conditions and questionable for others. Second, hidden costs matter. The side effects that affect your daily life are not trivial. They are biological signals that deserve attention. Third, alternatives matter. There are better options for most people with uncomplicated high blood pressure. Options that protect you without diminishing you. Now, I know that is a lot to absorb. And I know that some of you listening may feel a sense of urgency, a desire to act immediately, a frustration that you have been taking a medication for years without being given this information. I understand that. I feel it too. But let me guide you towards something more useful than urgency. Let me guide you toward clarity, toward a calm, thoughtful, practical approach to what comes next. We have traveled a long way together in this discussion. From the initial question about that little pill you take every morning, to the overlooked problem of outdated prescribing habits, to the real-world story of Margaret and her slow, quiet decline. We have walked through the hidden mechanism of beta blockers, understanding how they slow your heart but also constrict your blood vessels, how they lower the number on the cuff but may not lower your central pressure, how they cause fatigue and weight gain and metabolic disruption. And we have arrived at 3 key insights that most people never learn from their providers. That context matters, that hidden costs matter, that alternatives matter. Now we arrive at the final part, the calm reflection, the practical takeaway, the path forward that does not rely on fear or urgency, but on clarity and thoughtful action. Because the goal here is not to make you afraid of your medication. The goal is to make you informed, to give you the questions to ask, to help you have a different kind of conversation with your provider, one that is grounded in evidence, in your own experience of your body, and in a clear understanding of what matters most for your long-term health. Let me start by reframing everything we have discussed in a way that is simple and actionable. You are not a failure if you have been taking a beta blocker for high blood pressure. You are not a victim. You are not stupid or naive. You are someone who trusted their provider, who followed medical advice, who did what they were told to do to protect their health. That is not something to regret. That is something to respect. The medical system is complex. Guidelines change. Information evolves. No one can know everything. The question is not whether you made a mistake in the past. The question is what you do now, with the information you have today. So let me give you a clear, practical framework for moving forward. I want you to think of this as your personal medication review checklist, not a command, not a demand, just a set of thoughtful questions to guide your next conversation with your provider. First, ask yourself why you are taking a beta blocker. Do you have heart failure? Have you had a heart attack? Do you have a specific arrhythmia like atrial fibrillation? If the answer to any of these questions is yes, there is a strong evidence-based reason to continue your beta blocker. The benefits in these situations clearly outweigh the risks. The fatigue and other side effects may be an acceptable trade-off for the protection the medication provides. That does not mean you cannot ask about lowering the dose or switching to a different beta blocker with fewer side effects. But it does mean that stopping the medication entirely should be approached with great caution and only under close medical supervision. If the answer to those questions is no, if you are taking a beta blocker simply for high blood pressure with no other heart condition, then the calculation changes. In this situation, the evidence suggests that other medications are likely to work as well or better, with fewer side effects. This is the situation where a thoughtful conversation about switching makes the most sense. Second, reflect on how you actually feel, not how you think you should feel, not how you compare to other people your age, how you actually feel in your own body, on your own terms. Do you wake up feeling rested or exhausted? Do you have the energy to do the things that matter to you? Can you exercise without feeling like your legs are filled with cement? Have you gained weight that you cannot explain by changes in your diet or activity? Do you feel like yourself, or do you feel like a dimmer version of the person you used to be? These are not trivial questions. They are not just about comfort or convenience. They are about whether your medication is supporting your life or diminishing it. And you deserve to have a provider who takes these questions seriously, who does not dismiss your experience as normal aging, who is willing to consider that the medication itself might be the cause. Third, educate yourself about the alternatives. The medications that have replaced beta blockers as first-line treatment for high blood pressure are not exotic or experimental. They are common, generic, well-studied, and widely available. ACE inhibitors, ARBs, and calcium channel blockers. Each has its own profile of benefits and potential side effects. Each works through a different mechanism. and each may be a better fit for your particular body than the beta blocker you are currently taking. I am not going to tell you which one is right for you. That would be impossible without knowing your full medical history, your labs, your blood pressure patterns, your other medications, your kidney function, your electrolyte levels, and a dozen other factors. But I can tell you that you have options, and those options deserve to be considered. Now let me give you the actual words to use with your provider, because I know that walking into an appointment and questioning a long-standing prescription can feel intimidating. You do not want to seem like a difficult patient. You do not want to challenge your provider's expertise. You just want to have an honest conversation. So here is a script, not to memorize, but to adapt. Something you can say that is respectful, informed, and collaborative. You can say something like this: I have been reading about the guidelines for blood pressure treatment, and I learned that beta blockers are no longer recommended as a first-line treatment for uncomplicated high blood pressure. I have also been noticing that I feel really tired all the time, and I have gained some weight, and I am not able to exercise like I used to. I am wondering if it might be time to review my medication and consider whether switching to an ACE inhibitor or an ARB or a calcium channel blocker might be a better option for me. That is it. That is the conversation. You are not demanding anything. You are not accusing anyone of anything. You are simply bringing new information to the table and asking for a thoughtful review. A good provider will welcome this conversation. They will appreciate that you are engaged in your own health. They will take the time to explain their reasoning and work with you to find the best path forward. If your provider dismisses your concerns, if they tell you that fatigue is just part of getting older, if they refuse to consider alternatives without a good reason, then you have information as well. Not about the medication, but about the relationship. And you may decide that it is time to seek a second opinion or to find a provider who takes your quality of life as seriously as your lab results. Let me also address the question of how to stop a beta blocker if you and your provider decide that is the right choice. This is not something you do overnight. Abrupt withdrawal from a beta blocker can cause a dangerous rebound effect. Your heart rate can spike, your blood pressure can skyrocket. You can experience chest pain, palpitations, even a heart attack. The standard approach is a slow taper over several weeks, sometimes longer, while simultaneously starting a low dose of the new medication. Your provider should give you a specific schedule and should monitor you closely during the transition. Do not attempt this on your own. Do not skip doses. Do not cut pills in half without medical guidance. This is serious medicine, and it requires serious, careful management. Now, let me step back and offer a broader reflection, something that goes beyond beta blockers and blood pressure. Because the lessons we have explored together apply to so much more than this one medication. They apply to every prescription you take, every supplement you buy, every health decision you make. The first lesson is that guidelines change. Medicine is not static. What was considered best practice 10 years ago may no longer be best practice today. That does not mean your provider was wrong to prescribe it then. It means that science progresses and our understanding evolves. The question is whether your treatment has evolved with it, whether someone has taken the time to review your medications in light of the latest evidence. Most of the time, the answer is no. That is not because your provider is bad or careless. It is because the system is busy, and medication reviews often fall through the cracks. That is why you need to be your own advocate, not out of mistrust, but out of partnership. You are the only person who is with you for every appointment, every prescription renewal, every decision. The second lesson is that quality of life matters. It matters as much as quantity of life, maybe more. What good is living to 90 if you spend your 60s, 70s, and 80s feeling tired, heavy, and disconnected from the activities that bring you joy? Preventive medicine is not just about avoiding death. It is about living well, about maintaining your energy, your mobility, your mental clarity, your sense of purpose. Any treatment that compromises those things had better have a very good reason. And for uncomplicated high blood pressure, beta blockers do not have that reason. The third lesson is that you have more power than you realize. Not the power to diagnose yourself or treat yourself or change your medications on your own. That would be dangerous. But the power to ask questions, to seek information, to bring that information to your provider, to be an active participant in your own care rather than a passive recipient of prescriptions. That power is real, and it is the most important tool you have for protecting your long-term health. So let me leave you with this. If you are taking a beta blocker for high blood pressure, and especially if you have been taking it for years without a review, I want you to do 3 things. First, do not panic. Do not stop your medication. Do not change anything tonight. Second, take some time to reflect on how you actually feel. Write it down if that helps. Your energy, your exercise tolerance, your weight, your mood, your sleep. Third, schedule an appointment with your provider. Not an emergency appointment, a regular appointment. And go in with your questions ready. Have the conversation. You may discover that your beta blocker is exactly the right medication for you, that your provider has good reasons for keeping you on it, that the benefits clearly outweigh the costs in your particular situation. That is a good outcome. That is clarity. That is peace of mind. Or you may discover that there is a better option, that switching to a different medication could lower your blood pressure just as well, protect you just as well, and give you back your energy, your exercise capacity, your sense of vitality. That is also a good outcome. That is progress. That is reclaiming something you did not even know you had lost. Either way, you will have done something extraordinary. You will have taken an active role in your own health. You will have asked the questions that most people never think to ask. You will have moved from passive patient to informed partner. And that shift, more than any single medication change, is what will protect you over the long term. Thank you for spending this time with me. Thank you for being curious about your health. Thank you for being willing to question, to learn, to grow. That curiosity is not just admirable, it is protective. It is one of the most powerful tools you have for living a long, healthy, vital life. Not by avoiding risk entirely, because that is impossible, but by making informed choices, by understanding the trade-offs, by partnering with your provider to find the path that is right for you, not just for your numbers. This is Dr. Narges, reminding you that your health is not a destination, it is a conversation. A lifelong, evolving, thoughtful conversation between you, your body, and the people you trust to help you care for it. Stay curious, stay engaged, and as always, take care of yourself.